we'll discuss a little bit more. We have had the privilege of being in this area of weight management and metabolic health combined for over 20 years, the two of us, and we had established ReU Health about 6 years ago, but we've been very privileged also to be involved in a number of organisations, both nationally and internationally. So Zana, it's okay. There are conflict of interest. Sorry, I thought I couldn't change the screen. And just to give a little bit of understanding of ReU Health, so we are a GP-led evidence-based weight management clinic established just on 6 years ago. We now have 15 bariatric medical practitioners and a couple of lifestyle consultants, and we deal with very skilled multidisciplinary teams involved in the area of weight management and, as I said, metabolic health. When we provide both medical and surgical weight management solutions, to date, we've got over 14,000 new patients, and we see about 200 or more new patients a month. And we are quite unique in what we do. And I think that's the beauty of being a GP-led clinic rather than being run, say, for example, by bariatric surgeons, which is the typical model. And I think it's very relevant because we can bring this back into the primary care setting, which really is where this conversation and management should start. And in Adelaide, we're intricately linked with Calvary Adelaide Hospital. We also see patients from all rural areas of South Australia, but also rural Victoria and the Northern Territory. So the outline for tonight, we're just going to touch on the statistics in overweight and obesity. We'll talk about weight stigma and weight bias. We can't possibly do a talk on weight management without addressing that issue. We'll outline obesity as a chronic health condition. Zana will then talk a bit about the hormonal regulation of energy balance and, as well as this, how to initiate the conversation around weight management in a primary care setting. The multidisciplinary team is key in appropriate management of people living with overweight or obesity. So we'll talk a bit about that. We'll then go into obesity staging, and this is really a very new area. We've been doing it for a while, but it's becoming more evident that we need to start talking about unhealthy adiposity, not just weight itself or BMI. We'll look at all of the evidence-based treatment options, both pharmacotherapy and surgical, and then referral pathways for the complex patients. So, statistics on obesity. So 2 out of 3 Australian adults and 1 in 4 school-aged children are living with either overweight or obesity. And the most recent data is the survey from 2017 and 2018. And if we look at just the patients, adult patients living with obesity, it's 31% of Australians. And worldwide, this statistic is increasing dramatically. And we've got that current trend showing that 2.7 billion adults worldwide will suffer from being overweight or living with obesity by 2025. So it's certainly very relevant. Weight stigma and weight bias. So what is this? What do I mean when we're talking about weight stigma and weight bias? Well, weight bias, it refers to the negative ideologies associated with obesity. Weight stigma refers to the discriminatory acts and ideologies targeted towards individuals because of their weight and size. And weight stigma is a result of weight bias. And unfortunately, the data shows us that healthcare is one of the most common contexts where weight stigmatisation occurs, and it can have very negative consequences on people seeking health or assistance with their weight, and therefore negative health consequences. But at the end of the day, it's just about eating less and moving more, isn't it? So we can probably end this webinar now. It's not quite that easy, and we're going to touch on the multiple factors which contribute to overweight and obesity. So obesity is a chronic health condition. Let's touch on that, because people will often be a bit uncertain about, for example, whether care plans can be used for obesity. So the World Health Organization in 2022 made this statement: obesity is one of today's most blatantly visible, yet most neglected public health problems. And I think that's a very poignant statement. In 1997, the World Health Organization actually declared obesity to be a chronic health condition, a disease. Over the last decade, we've had all these different organizations, so World Obesity Federation, American Medical Association, and all of those listed on the page here, who have defined obesity as a disease. Unfortunately, Australia is a little bit behind that. But there is currently a Lancet World Commission going on, which is going to recategorise obesity. So not just based on BMI, which is the traditional way. And Zana will talk a little bit more about staging of obesity, which refers to, as I mentioned before, unhealthy adiposity. So obesity is a multifactorial disease. What is it all about? On the left-hand side, nutrition and physical activity. We know that's a key, and that is the foundation no matter what management options we're talking about. But there are other factors, and this is a very simplified diagram. The one at the top, we've got genetics. Well, that's one we can't control, but when you ask patients, you'll get the family history that multiple people in their family are living with obesity. Maybe lots of them have had different procedures for their weight. And so they will often come with their own views about what that means. And sometimes we have to dispel some of the myths associated with that. Then we've got medical conditions which can contribute to overweight and obesity. I mean, we all know about thyroid, and everyone hopes that their thyroid or their hormones are out of whack. It's not often a simple solution like that. But we've also got medications that sometimes we, as general practitioners or primary healthcare providers, are guilty of starting patients on and maybe not being aware of the consequences. For example, someone with chronic pain, we might start them on pregabalin or Lyrica, and that is well known to have consequences on weight gain, as are some of the antipsychotics and antidepressant medications. There are multiple medications, and yes, they have their place, but we need to be cognizant of the effect it might have on someone's weight. We've got our environment, and that includes both personal environment, psychosocial environment, but also the broader community environment. We're a fast food society. We have very highly processed foods, and there's certainly an abundance of them, and it's very easy to access, and we're becoming more sedentary. But we're going to talk more in depth about the endocrine system, so the hormonal play, and the nervous system, particularly the central nervous system. And Zana's going to be touching on that, and where, how our peripheral hormones can actually signal centrally in the brain to the messages which can control hunger, appetite, and satiety. So we all know this, working in primary care settings, that obesity impacts multiple organ systems, pretty much everything in the body. It transcends every discipline of medicine. I often like to look at it as the 3 M's, which is the metabolic or medical, the mental health, and the musculoskeletal. And so we can look at it in that way. We also know that, as well as the organ systems and the psychosocial impact and the mobility impact, we've got the oncological. We know that there are at least 13 different cancers associated with obesity, particularly a BMI over 35. and immunological as well. So we know, and we see it all the time in our patients, things like non-specific inflammatory markers like CRP, C-reactive protein, and watching the progress of that as people are losing weight or on some of these therapies, which can directly have an effect on inflammatory markers. So I'm now going to actually hand over to Zana, and she will talk a bit about the hormonal regulation of energy balance. Thanks, Zana.
Great, thanks, Teresa. First of all, before I start on a bit of physiology back from our medical school days, well, I guess we weren't really taught much about the way that weight is controlled back from our medical school days. And I believe really that there still is very little that's taught in med school. I think about an hour when we last asked some med students recently, which is quite abysmal. So we will talk a bit about that. I do want to say that there is a chat function that you can put some questions in. Teresa and I are very, very happy to take questions as we go along. We don't want to make this purely didactic. So if you've got questions about any of the slides, we're very happy to answer them, and we'll try as best we can to monitor those as we go. So hormonal regulation of energy balance or weight control. Let's have a little bit of a talk about that. Now, to try and not scare you, I'm just going to put up a diagram. There will not be a test at the end of this, but really this is just showing the neurohormonal factors involved in energy balance. So on the right-hand side, we have food that's ingested, which is mainly made up of carbohydrate, fat, and protein. And the ingestion of these foods triggers the release of various hormones, such as ghrelin. Ghrelin is our only hunger hormone that's been identified in the body. And then we've got a lot of satiety or fullness hormones. There's a couple of main ones. You can see them on the right-hand side here. So the main one we are going to talk about is today's GLP-1 or glucagon-like peptide 1. There's a whole lot of others. There is PYY, oxyntomodulin, CCK. There's a whole lot of them there, and they are released partly on stretch of the stomach, but also ingestion of foods. So in addition to this, we have various peripheral organs, and these are along the bottom. So we've got the adipose tissue, the pancreas, and the liver. And these all release hormones to signal about the nutritional status of our bodies. So whether we are nutritionally replete or not. On the left-hand side of the diagram, we have the brain. And we know that all of these hormones do actually act at the level of the brain. And the area of the brain that assimilates all of these hormones is the hypothalamus. So it's really the integration center or control center, as I like to call it, that integrates these signals from the body to regulate energy balance. And in fact, each one of these signals actually acts on a different nuclei within the hypothalamus to regulate energy homeostasis. And so any disruption to these signaling pathways can really affect overall energy balance and hence weight. And as you can see, there is a lot of areas along this pathway or places in this pathway where things can actually go wrong. The final part of this diagram is these other two areas of the brain. So the prefrontal cortex and also the reward system. So the reward system, I also like to call it the addiction center. This is the area of the brain that's really in control of anything that we can get addicted to, things like alcohol, it might be gambling, it might be amphetamines. And we also know that we can get addicted to food. And so that controls this area of this area of the brain controls that. We also have the prefrontal cortex, and that's involved in our decision making. So the decision to eat. So Teresa might bring in some cupcakes for morning tea into the office. And even if I've just eaten lunch, I really like cupcakes. So I might decide that even though I'm not very hungry, I'll decide to have a cupcake. And the thing that I want to get across is the prefrontal cortex, that decision-making area, and this addiction center or the reward center of our brain can override any of the signals coming back to the hypothalamus that signal whether we're actually hungry or not. So they can override that. So that's a really important thing to understand. This diagram is a bit of a more simplified one that Teresa and I use in our clinic with our patients. And it really just shows that area of the hypothalamus that does integrate those signals to let us know whether we are hungry or content. And we use this to really show our patients that it is a little bit of a complicated system, and that really part of that is actually out of their control. So the question that you might get asked, and we get asked all the time, is why is it so hard to actually keep weight off when we lose it? So this explains it a little bit. We've heard our patients quite often actually say, I've lost weight so many times before, and every time I do that, I not only regain the weight that I've lost, but sometimes I regain more than I actually did, and they'll get higher and higher. That's a common story that we hear in practice. So why is that? So when we lose weight, and it doesn't actually matter how we lose weight, it could be through a diet, it could be medication, it could be any of those ways. What actually happens is ghrelin, our hunger hormone, increases when we lose weight. The satiety hormones I talked about, so those hormones that make us feel full, they decrease. And coupled with that is a reduction in our resting metabolic rate. So that then causes us to feel more hungry, less satisfied with the same amount of food, and then our bodies will, our energy expenditure reduces. And so that therefore leads to weight regain. So if you think about it, it is not the way you would design a human to function this way. But it's a really useful way to explain it to our patients, as to be able to say to them, look, this is not your fault when you lose weight. All of these things are going against you, and hence the reason that quite often you will regain that weight that you lost, plus some. So the next thing that I want to talk about is, how do we initiate the conversation in general practice around weight? So for Teresa and I, now that we purely work in this area, it's actually quite an easy conversation. So patients come into our clinic, they want to talk about their weight. They know that they're going to talk about that because they've booked the appointment, and we are purely a metabolic clinic, so they expect to talk about it. But how do you, in general practice or in your allied health practices, how do you bring up that conversation? Well, we know that actually there are quite a lot of barriers to actually, first of all, identifying the issue, let alone bringing up the conversation. So we know that in primary care, only just over 22% of patients actually have their BMI recorded in the electronic medical record. And only about 4.3% have a waist circumference recorded. And these are two of the pretty basic measures that we can actually use to identify that issue in the first place. We also know that less than 1% of GP consultations actually centre around the issue of weight. So if you think about all the conditions that we see on a daily basis, when weight is actually brought up, less than 1%, that's not a lot. We also know there was a big study, the Action IO study, and there was a particular arm of that study, the Australian arm, that looked at how long it takes our patients to present to a healthcare provider and bring up the issue of their weight. And believe it or not, it takes on average 9 years from when an individual first starts struggling with their weight to when they actually first discuss it with a healthcare professional. Now, that's a very long time for them to be struggling with it on their own before they actually bring it up. So that's quite significant. So why might this be? Well, Teresa's mentioned stigma, and we know that that actually plays a really big role. We know in the study, that Action AU study, that when they asked patients about why that might be, they actually were afraid to bring it up with their general practitioner for fear of being judged about their weight. They thought that their problem would not only be dismissed, but that the doctor would purely just talk to them about exercising more and eating less. So that's what the patients thought. When the healthcare providers were asked, they actually thought that the patient didn't want to talk about their weight. and that there was almost a fear of offending them in bringing up the conversation. So there's that issue of, I guess, a mismatch in agendas here. We also recognise that for some people it is a difficult conversation or discussion to initiate because we may not know how to bring that up, and we'll talk about how we might do that in your consultations. There are time constraints in general practice. Rarely do patients ever come in saying, I want to talk about my weight. They might, but quite often it'll be that throwaway line at the end of the consult. Oh, by the way, I'm going to talk to you about my weight at some point. And therefore, we don't really have time to talk about it at the end of a consult. There are limited resources and referral options available. Now, we will talk about a few of them towards the end of the presentation. Inadequate equipment. I do want to talk a little bit about that. So patients will describe feeling more stigmatized when they come in because a clinic may not have scales that actually goes up to a weight that can actually weigh them. Some of our patients have come in and said that they actually needed to go to a weigh bridge at a veterinary clinic or in the Woolies loading dock to actually get weighed, which is really embarrassing for them. It's really important to have blood pressure cuffs big enough to actually fit their arm and big enough seats that they can actually sit in the waiting room and actually feel comfortable. So that can be a barrier as well. Then, as I talked about, the differing priorities between us as healthcare providers and also our patients. So how do we overcome these? So the one thing Teresa and I, when we were talking about this presentation, was we know that it's really important to make our patients feel safe. And by safe, I mean safe enough for them to be able to talk about their weight in a way where they feel they won't be judged by us as healthcare providers. We know that up to 60% of morbidly obese individuals have had some form of major trauma in their life, not always childhood sexual abuse. It could be the death of a loved one. It could be a whole lot of reasons, but 60% is a huge statistic. So we just have to be very, very mindful of that in our questioning. Our patients, these particular patients are really vulnerable. They're scared, they're embarrassed about their chronic condition, and there's quite often this is coupled with feelings of guilt and a feeling of failure. They've tried to lose weight before and have been unsuccessful, so they really feel like they actually haven't done a good job. The language we use is also really, really important. Some people don't even like the word obese or obesity. So we now sort of talk about those living in a larger body. So our patients may find it nicer to use that phrase, or having excess weight or excess adiposity. We need to also make them feel physically comfortable. Like I did talk about having the suitable chairs, the larger blood pressure cuff, adequate scales, and also having those within the room instead of saying, oh, let's go out into the back where our big scales are. We need to really make sure that all our rooms actually have that equipment that's suitable for them. Asking permission to actually talk about their weight. I know that sounds like a very, very simple thing to say, but even literally asking it like that, would it be okay if we talk about your weight today? You'll very soon find out if they're actually willing to talk about their weight if you ask it in that manner, but it's in a non-threatening way. We also need to assess their readiness to talk about the condition, just like we would their readiness to reduce smoking or reduce their alcohol consumption. We need to think about weight in the same way. We also like to link it back to chronic health conditions. So I said that patients rarely ever present to talk about their weight as a single topic. So one way you could link it back, if they're coming about their painful knees with their osteoarthritis, you could easily put a question back to the patient and say, look, do you think there are any factors that could be contributing here? Quite often a patient might say, well, yeah, my orthopedic surgeon told me I could lose a bit of weight. That's an easy in by being able to say, well, maybe we could talk about your weight today. Similarly, with their diabetes or any other chronic condition, we can always link that back in a way around weight. So let's talk about now the importance of or the multidisciplinary team in managing this chronic condition. So as with all conditions, we have a patient-centric approach. So the patient is the centre of everything that we do. It's no different to any other chronic condition. And there may be times where we need to involve many other healthcare providers. So we've got the patient at the centre, and then we've got these other healthcare providers. So some of you may be lucky enough to have dietitians or exercise physiologists either on site or in other practices that work very closely to you. And it's all about finding your tribe of practitioners that you know are able to deal with patients' weight in a very sensitive way. You might have practice nurses. They can be a really valuable asset, particularly when it comes to care plans. Psychologists are also vital. I did mention that up to 60% of people that are morbidly obese do or have had some major form of trauma in their life, and bringing up in a sensitive way, trying to access their, access to a psychologist so they can work through some of these issues is really important. Then on the periphery, and I don't mean to put them on the periphery, meaning that they're less important, but a lot of other chronic health conditions, like I said, can be linked back to their weight. So they might need to be referred to a sleep physician or a respiratory physician for a sleep study for sleep apnea. Cardiologists for the cardiovascular disease. Hepatologists for things like fatty liver disease. Endocrinologists for assistance with type 2 diabetes management or type 1 diabetes management. The renal physicians for chronic kidney disease, which is also linked to excess adiposity. Patients might also present to you wanting to, for assistance with fertility. They may either present with primary or even secondary infertility, or may have in fact been referred back to you from a fertility specialist with a request to lose weight prior to their IVF. That's a common one that Teresa and I see all the time. Our clinical pharmacists can be really invaluable at helping us to go through a patient's medication list to identify some of these medications that may be linked to excess weight. We also can't forget the orthopaedic surgeons. You might have had patients referred back saying, I need a hip replacement, but my orthopaedic surgeon has told me I have to lose weight first. And we can't forget our bariatric surgeons as well. So some patients might present to you asking for a referral to a bariatric surgeon, or you might even have that conversation with them if you're privileged enough to be in a position where you have a great relationship with your patient to be able to talk about the option of bariatric surgery, and we will talk about that later. So there are a lot of people on this slide, and a patient may not need all of them, but they quite often will need at least 3 or 4 of them to help managing this chronic condition. So let's talk about staging of obesity now. So in 2009, there was a guy called Arya Sharma and his colleagues, and they put together it was a different staging system for excess adiposity, and they were really quite ahead of their time. So they're some Canadians, the Canadian Obesity Foundation. They have a lot of really great resources to use. But Arya Sharma and colleagues put together this system, and it really is a staging system from stage 0 right through to stage 4. And it looks at the medical complications of excess adiposity, the psychological complications, and also the functional. And you can basically score them individually and get a bit of an idea of where a patient is or how that excess adiposity is affecting the patient. So stage 0 would be if they're not really having any complications of their excess weight, right through to stage 4, which would be end stage. And this is a really useful one because we do see patients that may have excess adiposity that may actually be functioning quite well. They may not be breathless. They may not have osteoarthritis, but psychologically, they may be really feeling the effects of their weight, and it might be causing some significant depression or anxiety in their life, and they may not want to go out socially because of their weight. We hear that quite a lot. Alternatively, they may psychologically be okay, but medically, they might have type 2 diabetes, elevated systolic blood pressure, sleep apnea, a whole lot of things that actually are causing them significant harm, even though psychologically they may be okay. So this is can be something that we can talk about with our patients in how the excess weight is making them feel, and we can stage it that way. This is a chart that we use in our clinic. I know we have talked a little bit about BMI. BMI is a little bit outdated, and we're going to be able to, that system is going to change over the upcoming months. But at the moment, a lot of the medications that we use and even the qualifying criteria for bariatric surgery are still based on BMI. And so we quite often go through this chart just to show the various options that a patient has open to them, and it's a really useful way to sort of a visual as to what options are available. So lifestyle management or looking at diet and physical activity are the cornerstone of our management, and it's important to talk to them about that through all the classes of excess adiposity. And as they get an increase in their adiposity, it really does, I guess, open up a lot more treatment options for them. So now we're going to talk a little bit about the evidence-based treatment options for our patients depending on their size. So this is another way that we can talk to our patients about options. So along the bottom, we've got the amount or the percentage of total body weight loss that the various options can provide. So with giving them some lifestyle advice, so about diet and physical activity, patients can typically lose about 5% of their total body weight, and that's not insignificant. I think we really underestimate sometimes the effect of if in a person that's, let's say, 100 kilos, even losing 5 to 10% of their body weight, that's actually really meaningful for some people, and they will notice differences in reduction in pain and those sorts of things. So I think we can't minimize that effect, but we do know that by using diet and exercise alone, being able to keep that weight off long term is extremely difficult, and less than 1% of the population will actually be able to lose weight and keep it off for life in that manner. Moving along, we've now got some very effective I guess, obesity management medications that we can use that provide anywhere from sort of 5% total body weight loss right through to now up into the 20% total body weight loss, which is pretty impressive. We'll talk about those a little bit later. Teresa's going to talk about those. There are also some intragastric balloons. So some names that you may have heard. There's a SPATS-3 balloon, an Albira balloon, and now a balloon that people can swallow that doesn't require an anaesthetic called the Allurion balloon. And they're providing around that 10 to 15% total body weight loss, which is another option for a lot of our patients. Then we move on to bariatric surgery, so sleeve gastrectomy and gastric bypass, which typically provides in the order of 25 to 30% total body weight loss. And then we've got other procedures like biliopancreatic diversion, which provides quite a lot of malabsorption, which is the way it provides a lot of weight loss, and you're looking up around the 35% of total body weight loss. So in terms of BMI and eligibility, when we're looking at patients that have a BMI of around that 25 to 27, we're looking at providing some lifestyle management, a lifestyle and behavioural change, so healthy eating, increasing physical activity, and also we can't forget the importance of psychological intervention as well. When we're moving up towards the BMI of that 27 to 30, then it opens up some other treatment options. So looking at the very low calorie diets and also some of the obesity medications, which are providing, like I said, around anywhere from 5% up to now about 20% of total body weight loss. Then when our patients get to a BMI of over 30, we can start that conversation potentially of saying you are actually eligible for bariatric surgery. So for bariatric surgery, the qualifying criteria would be actually a BMI of over 35 or It's actually changed now. So, or a BMI over 30 with at least one weight-related complication. And we'll talk a little bit about the options of bariatric surgery soon. The next generations, they're the ones we'll talk about as well, which are producing some pretty impressive weight loss. So this is the Australian Obesity Management Algorithm, and a lot of you may have seen this. This was updated recently. It was updated to include waist circumference, as you can see up the top on the left-hand side. So we're not only talking about BMI, but those factors that are really the medical, psychological, and physical things that are as a result of the excess weight. And it is a bit of a nice flow chart to go through. You can use it with your patients, but also even just yourselves as a bit of a refresher as to which options are available for our patients depending on their BMI and how their excess weight is affecting them. So now I'm going to pass over to Teresa, who is going to start with some dietary options for our patients.
Yeah, thanks, Anna. So, as Anna said, with regards to dietary options, we can be looking at that sort of 5% mark of weight reduction, and that can be clinically meaningful for some patients. There are a multitude of diets, though, and most of our patients have tried the majority of them, and it can become very overwhelming. It can become overwhelming for us as healthcare providers to know what the latest trend is, let alone for our patients. And of course, social media provides a lot of complications as well. A lot of these diets are typically restrictive, and that won't work in the long term. Any diet that we do recommend or any diet that a patient is on needs to be sustainable over a long period of time. So we use the word diet in our clinic to mean the food that people are eating, how they're nourishing their body, rather than the traditional understanding of diet is that someone is on a diet, they're restricting themselves, they're doing a program for a period of time. We really need to reframe that and talk about how they can improve their dietary intake for the long term to improve their health long term. We do know a few things with diet that's very useful. So protein definitely increases that feeling of satiety. And so trying to include protein in their diet, and not just traditionally, we're very good at having protein with our evening meal, but encouraging patients to be mindful and think about their protein intake in every meal that they have during the day. There is also some evidence for specific diets, particularly the Mediterranean low-carb diet. There is some evidence, particularly in the cardiovascular realm, improvement in blood pressure, and improvement in some other cardiovascular outcomes, and also in intermittent or time-restricted fasting. However, the evidence for that now, there's been a lot of postulation about the effect on insulin and insulin stabilization and glucose. But now the belief is that actually for most people who are on either an intermittent or time-restricted fasting program, it's because their overall intake is less because they're eating for less hours. Again, people will sometimes say, should I be doing this? And my comment will often be to them, is that something you can see yourself doing in 5 or 10 years' time, or for the rest of your life, basically, which is what we're trying to promote. The best diet incorporates high quality food in appropriate portions, and it's got to be acceptable for the patient as well, for their lifestyle, for their family life. And we need to remember that there is no one perfect diet that will suit everyone. I will give a plug to another webinar which is happening in about a month's time, and that is nutrition for weight management. And so they're going to be delving in a lot more detail, and it's a group of dietitians that we work very closely with as well. So I will just touch briefly on the VLEDs, or the very low energy diets, because the charts that Zana showed mention these specifically, and they definitely have their place. They're not acceptable for all people. You know, people may say, I want to eat my meals with my family. I don't want to be sitting there having a shake. So, but for some people, they can be beneficial. And at the end of the day, these are used to reduce dietary energy intake and induce ketosis. And ketosis contributes to fat burning. It's indicated in those who are overweight or obese, so that BMI above 25. Available as meal replacements such as shakes, soups and bars. And there's a lot more options available for patients now. You know, some people will say, oh, I've tried those sort of things and I hate them, but it is worth just revisiting because there's not just one brand of these. It can be done as an intense or modified program. So the intense is intense and it's not a sustainable program. That's when all meals are replaced by the VLEDs. So VLEDs basically high proteins, low carbs, and they do have some nutrition in them. And so it can be used to replace all 3 meals. We use that program traditionally in patients who are being worked up to bariatric surgery. Most surgeons will request 2 weeks of an intense VLED program to reduce visceral adiposity and shrink the size of the liver to make the operation safer. When people are doing the intense program, on average, they can lose 1 to 2.5 kilos per week. The minute, though, they divert from the structured program, they take themselves out of ketosis, and it takes another 3 days or so to get themselves back into ketosis where the fat burning will occur. It can be done as a modified program as well, where people may replace just 1 or 2 meals a day. And I find that particularly useful for patients who say, oh, you know, I'm not a breakfast person. I can't have breakfast, or I don't have time for lunch. I'm not organised or structured. And so in that case, whilst I like to promote whole real foods for my patients, I think the benefit of having a VLED as opposed to completely skipping meals is beneficial in getting people into that regular meal pattern. And there's a good resource there from the Baker Institute going through how to educate people on VLED diets. One thing I'll say about them is that some patients think that the meal replacement shakes are like a snack. No, they actually are replacing an entire meal. So what is the evidence behind dietary options? So this was a systematic review, and they used 121 RCTs, so randomized controlled trials, and over 21,000 participants. And they looked at various diets and they categorized them into low fat, such as the Ornish diet, low carbohydrate, such as Atkins and Zone diet, and then moderate macronutrient diet, which includes the Mediterranean and DASH diet. And there were a number of others, but they were the most common ones. And they looked at this versus usual diet without any specific extra advice. And the summary of this very large systematic review showed that most macronutrient diets, when you look over a 6-month period, result in modest loss of weight as well as improvement in blood pressure. So they're always looking at the cardiovascular outcomes with a lot of these dietary modifications. And we're talking sort of between 2 to 6 kilos. But at the 12-month period, weight reduction diminished and blood pressure improvements largely disappeared. So there is no one diet that is the absolute perfect diet.
Teresa, we've actually got a question which relates to VLEDs. And the question is, what VLED products do you use?
Yeah, so traditionally in the medical setting, and certainly a lot of hospitals will use Optifast. If you look at the Baker Institute information, the 3 that they recommend, and the Baker Institute is in Melbourne and they've done a lot of research around this, but Optifast, OptiSlim, and Formulite. So they're the three that are traditionally used. Having said that, there are many on the market, and I know our lifestyle consultants will often modify that to suit the patient. So some will say, oh, they're really expensive and I can't afford them. There are some Aldi, meal replacement shakes that can be used. What you really need to look at is the protein content of these and make sure they're not too high in sugar and carbohydrates. But those three are traditionally the ones that are used more in a medical setting.
And next question leading on from that VLED is how long do we get the patients to use them? And I know this is a bit of an open-ended question, but yep.
Yeah, absolutely. So I think, as I mentioned, if you're doing the intense program, I think we do it pre-surgery for 2 weeks. I think people can do it for a bit longer. Sometimes we'll do a prolonged VLED, maybe for 4 to 6 weeks. At that point, you do need to start monitoring their bloods as well. The modified VLEDs, where you're replacing only 1 or 2 meals, though, can certainly quite comfortably be used for much longer periods of time. And if they're replacing breakfast or breakfast and lunch, with their evening meal, we still encourage high protein and low carbs to kind of keep that pattern going. So, and Zana, you might want to add to my answer to this, but I think at the end of the day, it has to suit the patient. It has to suit their family as well and their particular lifestyle. If they're very social, it's very hard to do an intense VLED and maintain that.
Yeah, I absolutely agree with Teresa. I think the only other thing that I'll add is that there are some people that absolutely love VLEDs and they will use them intermittently over their lifetime. I know not just women, but some men as well who will say they use it, for it might be 6 or 8 weeks just to get their weight under control. Then they might go back to normal eating. And if their weight escalates, they'll quite often jump themselves back on that if they really realize it's a really good option for them. And yet there are others that really dislike it and doesn't fit with their family. So I think it really comes down to individualizing the option for the patient.
Thanks, Anna, for adding to that. Now, I wonder if perhaps because this next section is quite gutsy, whether we might have a small break, because we're going to talk about pharmacotherapy, and I'll be going through all the currently available pharmacotherapy options, and then Zana will talk about both intragastric balloons and bariatric surgery. So we might just pause there and I'm not sure, maybe 5 minutes?
I think 5 minutes should be fine. We'll be back at 7:55.
Fabulous, thank you.
Thank you, Teresa. Teresa, there is a question in Q&A.
Yeah, I saw that. Thank you. So the question was, can keto diets lead to high cholesterol and LDLs? Absolutely. I think one of the things with keto diets and keto diets can also be very difficult to stick to if you do the intense keto diet. But keto diets are basically very high protein, which we did say there was certainly a benefit to high protein in terms of maintaining satiety levels, but also high fat. And so certainly we do see those high cholesterol and LDL levels. So thank you for that question, and please continue to ask questions. Now, I think Zana and I have set the scene. It may have seemed a bit boring, but I think it is relevant for any discussions that you have with your patients about weight management. But, important to understand the basics, the stigma that patients feel, using the right language, and also the pathophysiology, so that if we can explain to them why they're regaining weight, I think one of the biggest things we can do to help our patients is educate them, let them know it's not their fault. But now here comes the gutsy session. So as I said, we're going to talk about pharmacotherapy. So there are now 3 pharmacological agents available and TGA approved in Australia for weight management. And the criteria is a BMI above 30 or above 27 with at least one weight-related comorbidity. And Zana and I feel like we're constantly changing the patient information we produce because there's new medications coming available. And we also change the order in which we put them in. In the past, we've put them in the order that they became available in Australia, but then we found that the injectables were all in a differing order. So you can see this is kind of the order that we explain the medications to our patients. The first 2, so Orlistat and Duramine or Phentermine, they've been around for a long, long time, and most of us are familiar with them. We've got now Trexone and Liraglutide, which we call our first generation new obesity management medications, and then semaglutide and tirzepatide, which are the second generation medications. This is a chart that Zana and I, as I said, have put together to explain it in one simple format for our patients. We look at the average weight loss, we look at side effects, we look at how these medications are delivered. So I'm going to now delve into more detail about each of these medications because most of them do have a place to play. I think one thing I'll mention is that none of these are PBS listed, so cost can be a bit of a factor for patients. And also, interestingly, that 5 out of the 6 all work centrally in the brain. So Orlistat is the only one that doesn't. So that's the importance of what Zana mentioned earlier about the brain's accumulation of those peripheral signals when we're controlling appetite and food intake. So the first medication I'll talk about is Orlistat or Xenical. It's been available since 2000. It's an inhibitor of gastric and pancreatic lipases, and it reduces the absorption of dietary fat by about 30%. Now, one of the side effects the main side effects occur because of the way in which it works. So steatorrhea, increased flatulence, and sometimes fecal urgency and even incontinence. So not very pleasant side effects. It is contraindicated in pregnancy and breastfeeding, and you'll see that that's the case with all of these medications. And we do need to use caution if we're using them following bariatric surgery, because it can cause something that we call dumping syndrome. And Zana may go through that a little bit more when she's outlining bariatric surgery. But it's not pleasant, and it can make those side effects of steatorrhea and fecal incontinence even more prevalent. The average weight loss with this medication is fairly minimal. We talked about lifestyle modifications. We're looking at that 3 to 5%. Orlistat's really not giving us much more, but with some fairly significant side effects. It does come as an oral capsule. Oral medications for some patients are more acceptable than injectable medications, although I will dispel that myth, I think, as I talk about the injectables. And it's usually used 3 times a day, so with every meal. Certainly, I've had some people who have used this in the past. It's not something I would recommend to most patients, but have used it, and they'll say, oh, when I'm having a fatty meal, I won't take the tablets. So it kind of defeats the purpose in that respect. It's about $95 a month. Yeah, as I said, it's certainly not used very often. It is available over the counter. A lot of people have tried it, and the minute you mention the word, they'll often talk about the side effects. So we're just now going to talk about phentermine or Duramine. Most patients also, this is a common one that they will have tried, and most doctors have probably prescribed it. It was TGA approved.
Sorry, Teresa, just one question, and this is not a TGA approved medication for weight, but there's a question that's come up about low dose metformin. Did we want to talk about that before we moved on to the other TGA approved medications?
Yeah, absolutely, we can. So we do know that metformin can be useful. For some people, it can reduce appetite and it can have a slight weight reduction benefit. As Zana said, it's not one of the TGA approved medications, but certainly women in particular with polycystic ovarian syndrome and insulin resistance, it can absolutely be a valuable adjunct, and it would often be something that we would recommend as a starting point in those patients, and it is a cheap medication. So thank you for that question. So yeah, phentermine or Duramine, been available for a long time. It's a sympathomimetic amine. It reduces appetite by stimulating the neural release of noradrenaline, serotonin, and dopamine. Because of this, again, that contributes to some of the side effects, and most of us will be familiar with patients experiencing these side effects. So anxiety, hypertension, tachycardia. Insomnia can be a very significant one, and it can really be very counterproductive. We know that sleep and sleep hygiene is so important when we're looking at lifestyle modification and weight management. So we certainly don't want to be affecting someone's sleep pattern. Dry mouth, that's usually a manageable one. So contraindications. CAD, so cardiovascular disease, uncontrolled hypertension, and cardiac arrhythmias, so that cardiac profile. Hypothyroidism, particularly not well managed hypothyroidism. Glaucoma. Contraindicated use in conjunction with monoamine oxidase inhibitors, which we don't use very commonly these days, but we have to be aware. And as I mentioned, pregnancy and breastfeeding, all of these medications are contraindicated. It's not recommended with SSRIs, but it can be used. The average weight loss, we're getting to that sort of 5 to 6.6%. And as we said, that 5 to 10%, we are starting to notice clinically significant benefits. So reduction in blood pressure and sugar and insulin levels in particular with that sort of percentage weight loss. It comes as oral capsules, and we have 3 different dosages, 15, 30, and 40 milligrams. And it's about $135 a month for the highest dose. I think there is a question there. With phentermine, when you stop it, do you get rebound in the weight? I'd have to say yes, absolutely. I think traditionally this has been used as an appetite suppressant, and people who respond to it, they get such significant appetite suppression that they often don't want to eat at all and really starve themselves or just restrict themselves to 1 meal a day. Of course, as soon as it's stopped, that appetite comes back with a vengeance. And so we do find traditionally that people do regain weight very quickly after stopping Duramine, and I'd have to say much quicker than the evidence with GLP-1 receptor agonists, which we'll talk about in a moment. The other thing I'll mention, and this is not available in Australia, but a medication called Qsymia, which is in the States. It's a fixed dose combination of phentermine combined with topiramate. So if we're using that in Australia, it is off-label prescribing, and you obviously have to use both medications in conjunction. Now, some people might need topiramate for migraine management, and really severe migraines can cause a lot of problems with sleep deprivation. And so again, if we can manage migraines, that's great. The fixed dose combination comes as, the dosage starts very low with the Duramine component, and it's about, it's a low dose that we don't have. So I think it's about 2.5 milligrams. Clearly we can't start with that sort of dose. But the data behind Qsymia, the fixed dose combination, is actually quite impressive as well. And it does give that 5 to 10% weight loss.
Couple of other questions while we're on phentermine, Teresa. First one about any risk of dependence with that.
Yes. No, look, the safety data and profile has been analysed quite extensively, and it is a safe drug to use. We do need to, just like with any of these medications that we're using for a chronic health condition, we need to monitor the patient regularly. And probably one of the most significant thing is monitoring their blood pressure, because a lot of patients who are living with obesity will also have issues, maybe with borderline blood pressure. They may not be on treatment, or they may be on treatment. So just like anything, monitoring for side effects, including hypertension and insomnia, and of course any suggestion of cardiac issues. It was banned in the UK many years ago. And that was the combination of fenfluramine, and it was with cardiac valvular disorders. It actually wasn't the phentermine component that was the issue, and phentermine has now been studied extensively. So the idea that you can only use phentermine for 3 months has been dispelled, so you can use it for longer. But like I said, the monitoring, of this medication, I think, is crucial. Zanna, I'll pass to you if you've got anything else to add to that.
Yeah, no, I think that one's a really important one about the duration. I mean, it was listed in MIMS, and I think maybe still is, about that 3-month rule. We now know that any of these obesity management medications, if we do stop them, patients will get rebound weight gain. The degree of that is variable, but if a patient is tolerating a particular option, they are coping with the side effects, and it's a treatment option that they are getting benefit from, then there is actually, provided it's monitored, then there's no reason to stop it.
There was one study, Zanna, that I remember now that it looked at use of phentermine over a 2-year duration, and it looked at continuous use versus intermittent use of the medication. And I believe, and you might have to help me out here, Zanna, but the intermittent use was found to be very effective, minimise the side effects, and actually the overall weight loss was a bit greater.
Yeah, it was. That's exactly the synopsis. Yep.
Beautiful. Now, let's move on to Contrave, which is a combination of naltrexone and bupropion. TGA approved in 2018, so liraglutide or Saxenda came out just a little bit before this, but Contrave and Saxenda was that next generation where we're kind of getting much more significant weight benefits and potentially less side effects for patients. And we finally had a few extra treatment options. So how does it work? It reduces hunger, but also importantly helps to control cravings. It reduces appetite by stimulating activation of POMC neurons in the hypothalamus, and I'll go through this in a little bit more detail in a moment. The side effects, so most of these side effects are transient, and we do escalate the dose gradually to try and minimise the side effects. So nausea and occasionally vomiting, constipation, headaches can be quite common, and dizziness. Insomnia can occur when we start to escalate the dose, and particularly if we're introducing a late evening dose. So we try to get patients not to take it too late in the evening if they are having issues with insomnia. So when we introduce the second dose, we normally start 1 tablet in the morning and then 1 BD. As long as there's 8 hours duration between the two, that's adequate. So sometimes maybe having it with the evening meal might be better than having it just before they go to bed. Dry mouth is another one, and again, usually transient and manageable. So contraindications, uncontrolled hypertension, but people with well-controlled hypertension can use it. Seizure disorder, bipolar disorder, we need to be cautious. Acute alcohol benzodiazepine withdrawal. Chronic opioid use, because it is blocking those opioid receptors, so the opioid analgesia will not work effectively. Again, any use in combination with monoamine oxidase inhibitors are contraindication, and pregnancy and breastfeeding. The weight loss, the average is about 6.1%, but in people who respond to this medication, it's around just over the 11% mark, which is starting to get into double digits percentage weight loss, which is very significant. What do I mean by responders? So responders are patients who have lost at least 5% of their body weight in the first 16 weeks. And this responder rule kind of came out both with Contrave and with Saxenda, which I'll be talking about next. The next generation of GLP-1s, we no longer use that responder rule. And I think we have to use it with caution as well, because if somebody is benefiting from these medications, even if they haven't quite lost that 5% in the first 16 weeks, I think we need to give patients the option as to whether they'd like to continue the medication or not. But like I said, if they respond early, we do see that generally they start to get more significant weight loss, and as I said, above 10% now. It is an oral medication. The starting dose is, as I said, 1 tablet a day. Each tablet contains 8 milligrams of naltrexone and 90 of bupropion. So the total, when they achieve the full dose of 2 tablets BD, is 16 milligrams of naltrexone and 100 of bupropion. Cost is about $250 a month if they're on that maximum dose of 4 tablets a day. So just let's revisit how and where it works. So if we look on the right-hand side here, we can see that it does work on the mesolimbic reward system, and Zana mentioned that craving or addiction center, and so it does help with the intense cravings, but it also works in the hypothalamus to assist with hunger suppression. So in the arcuate nucleus of the hypothalamus, bupropion is the primary component that is stimulating the POMC neurons. And POMC neuron stimulation helps with release of alpha MSH. And it's the alpha MSH that binds to and stimulates melanocortin-4 receptors. And it's the melanocortin-4 receptors that lead to reduction in appetite and weight loss. The naltrexone then kicks in by actually blocking the inhibitory feedback loop. So in effect, it gives more potent and longer lasting activation of the POMC neurons, and therefore more reduction in appetite. So in effect, bupropion and naltrexone together work synergistically to increase the POMC production. So these are the theories behind it. There is still some unknown about Contrave and how it works, but certainly when, in some of the trials that were done looking at the activation of that mesolimbic system using scanning methods, it was quite an impressive activation. So, when people were shown a picture of a food which traditionally they might get excited about, the activation of the mesolimbic system was there, and when they were on the Contrave, it minimised that activation.
There's a couple of questions here regarding a lot of patients that are carrying excess weight, as we know, have coexisting depression, and it's used with antidepressants. Teresa and we don't have any concerns usually about starting Contrave in patients that are on antidepressants, apart from the monoamine oxidase inhibitors. We know that there's some recent data that suggests that they are safe. Initially, when Contrave first came out, there was a thought that you had to reduce the antidepressant dose by a half. That is now known to not be necessary. We always counsel our patients about if they are on antidepressants, and we obviously monitor them. You're not going to put them on a medication and not review them again. So it's that constant reviewing process. But yes, it is safe. We do counsel them just carefully to monitor for symptoms and to come back if they do have any. However, we also know that bupropion itself is a mild antidepressant. So quite frequently what we know is that patients will often come back and say, actually, my mood has actually been a little bit better. When I was in Canada, bupropion is actually one of the most commonly prescribed antidepressants, and so I got very used to prescribing that. And it's actually amazing how well it actually works. So sometimes, even when we haven't educated our patients about the other use of bupropion, they'll quite often come back and say, I feel a little bit better. And sometimes we are able to reduce the dose of the other antidepressant. However, it's not entirely necessary.
So there's another question, whether there's any issues with Contrave and well-controlled schizophrenia. That's a tricky one to address. I think if it's well-controlled, I am comfortable prescribing it with much, much closer monitoring. There is the rare situation, even though, as Zana said, the bupropion, can be used as a mild antidepressant. There's very rare effects that some people can develop suicidal ideation. So I guess this comes in both with schizophrenia or any mental health issue, again, that it needs to be monitored. Zana and I have used Contrave for many, many years now, and I have probably had 2 patients who have actually come to me saying, you know what, I just didn't feel good on it. I was driving my car and thought, should I drive into that tree? But they were so aware, and these were patients actually without any underlying mental health issue. So I think the benefit that people can achieve, there's a very bi-directional nature with any mental health condition and weight. And so people who have been put on a lot of medications, and particularly some of the antipsychotics, have often gained significant weight. That significant weight has contributed to deterioration in their mood, their sense of self, their worthiness, their personal image, body image. And so if we can be willing enough to assist these patients and try some of these medications, it can have a profound effect on their mental health as well. So I would say, don't be scared to try these medications. As GPs, those in the audience who will be prescribing these medications, the beauty of being a GP is that we follow our patients up and they come back to see us. So yeah, I think just more frequent monitoring, but give it a go. I think the last thing that patients with known mental health issues want is to be told, no, sorry, we've got no options for you to assist with your weight, because we do have options.
And very briefly, last one, would we talk about the risk of increased suicidal ideation? I guess, yes, we do, but that's the same as with any antidepressant as well. We will talk about the slight risk of that, and again, the constant monitoring. So yes.
Yeah. So liraglutide 3 milligrams, or Saxenda. So that was our first GLP-1 receptor agonist. It was approved in Australia in 2015. Hard to believe it's actually been around for 9 years now. It reduces appetite and improves satiety by stimulating the GLP-1 receptors in the brain, which Zana highlighted. It also, though, does have effect on delaying gastric emptying, which increases that prolonged feeling of fullness and satiety. In terms of side effects, the majority are gastrointestinal side effects, so nausea, potentially vomiting, although again, we escalate the dose very slowly, and if someone still has ongoing nausea, I wouldn't necessarily be going up to that next dose until that settles. Constipation or diarrhea, so it can go either way. Slight increase in heart rate, but this shouldn't be clinically significant because on average it's about 2 to 3 beats a minute. Gallstones can occur, a slightly higher risk, but that's a higher risk with anyone who's losing weight. And acute pancreatitis, often gallstone pancreatitis. There was, in rodent studies, a slight increased incidence of thyroid medullary tumour. Rodents have more particular thyroid medullary cells. That wasn't equated in the human studies. So there's no known risk of thyroid cancer in humans, despite, again, the cautions that have been put out there. Contraindications, known sensitivity to the active ingredient, and again, pregnancy and breastfeeding, and it's category B3 in pregnancy. We do need to be cautious with a past history of pancreatitis, but if it was a very obvious situation of gallstone-induced pancreatitis and they've had their gallbladder out, I'm very comfortable prescribing it to a patient. The weight loss on average is about 8%, and in those responders, again, it's in that double digits, so 11.2%. It is a subcutaneous injection, and I think when it first came out in 2015, you know, we probably were a little bit hesitant when we were explaining this medication to patients. We have no hesitation now, and in fact, most patients know about the injectables, but even if they don't, the idea that it's an injection is probably one of the last things that I talk about, because I really want them to focus on how this medication works and if they think it would be beneficial. Starting dose is 0.6 milligrams, escalated on a weekly basis. It is a daily injection, and by week 5, in theory, they should be at the full dose of 3 milligrams. The 3 milligram dose is the dose that has been studied to look at this weight loss responder data, but I certainly know that I do have people who have been very successful on lower doses. And so, you know, this needs to be considered. And I suppose particularly in our setting, because we also do use pharmacotherapy after patients have weight regained after bariatric surgery, we'll use this commonly at a very low dose. So if they are at the full dose, though, 3 milligrams, it is $387 per month. If they manage at that lower dose of 0.6, that might last them 5 months. So GLP-1, there are GLP-1 receptors in multiple areas of the body. The adverse effects occur because of the GI effect of the GLP-1. Also the heart and the pancreas, which increases that risk potentially of acute pancreatitis. And in terms of the way it works on the pancreas, the brain, the stomach to reduce gastric emptying, as we mentioned, and also on the liver with increased insulin sensitivity and reduction in glucose production. And we know that the 1.8 milligram of liraglutide was a diabetic medication, so we know it's very beneficial in that respect as well. I'll go on, and there is a question there which I'll answer as we go through the rest of these medications. So semaglutide 2.4 milligrams or Wegovy. It was TGA approved in 2022, but it took a while to reach our shores, and it's only been available in Australia for the last 3 months or so. It is also GLP-1 receptor agonist. People will know semaglutide 1 milligram or Ozempic. So certainly our patients know of Ozempic. Semaglutide 2.4 milligrams was found to be more effective for weight management. The 1 milligram dose was very effective for glucose control, and actually escalating the dose more than that didn't provide a huge improvement in glycemic control. Again, it's a GLP-1, so it works by improving satiety by targeting those receptors in the brain and reducing gastric emptying. Side effects, exactly the same as Saxenda, so I won't go through them again. Interestingly, though, or importantly, the contraindications, it is classed as category D in pregnancy. And so typically we see, probably 70 to 80% of the patients we see are females, and a lot of them are in that childbearing age. So we need to think about contraception before prescribing these medications. Average weight loss, we're starting to see 15% average weight loss. And importantly, 1 in 3 patients will actually lose more than 20% of their total body weight. It is a weekly subcutaneous injection as opposed to daily. And the starting dose is 0.25 milligrams. There are 5 dosages, so 0.25, 0.5, 1 milligram, which, as I said, is the full Ozempic dose, then 1.7 milligrams and 2.4 milligrams. The cost at the highest dose is $460 per month, but at the lower 3 doses, it's about $250 a month. Again, if patients are losing weight effectively and managing at those lower doses, then that's great. Now, there was a question, which of the injectables is most effective and gives biggest bang for buck? I found Saxenda the least effective. So there has been a head-to-head trial of Saxenda or liraglutide 3 milligrams compared with semaglutide, Wegovy, and Wegovy at 2.4 milligrams did show about double the weight loss of Saxenda. So definitely we are seeing greater weight losses. I think Saxenda still has its place. And if we've got someone, when you look back at the obesity algorithm, if we've got someone who really only needs to lose 5 to 10% body weight, then Saxenda may be a very good option. And if they can successfully lose weight at that lowest dose, it is going to be a cheaper option for them as well. Another question, and I might come back to the next 2. Actually, I'll answer one of them. If a patient was on 1 milligram of Ozempic, can we change them to Wegovy directly? Absolutely. So straight to the 1 milligram. You don't need to start at 0.25. It's a direct swap. There is a question about using GLP-1s in the elderly. And as I said, I will go through the rest of the medications and then I'll address that question. So if we can leave that up there. Now, the newest kid on the block is tirzepatide or Mounjaro. That was TGA approved, well, actually in end of last year for treatment of type 2 diabetes, but only about 2 months ago in Australia for weight management. So this is a dual agonist. It works on both GLP-1 and GIP receptors. Again, 2 of our satiety receptors in the brain. It reduces appetite and improves satiety by stimulating the GLP-1 and GIP, as I said, in the brain. It reduces gastric emptying. So both of those are very similar to the straight GLP-1 agonist, but it also improves beta cell glucose sensitivity and insulin sensitivity. There is some evidence that the GIP component may reduce some of the gastrointestinal side effects of GLP-1, so maybe more tolerable if people are having side effects on either Saxenda or Ozempic or Wegovy. And also some evidence there are GIP receptors in adipose tissue that it may have some effect on fat cell metabolism. So side effects, nausea, constipation or diarrhea, abdominal pain, dyspepsia, and again, the gallstones and acute pancreatitis. So very much those gastrointestinal side effects. Contraindication, again, the only true contraindication is a known sensitivity to the active ingredients. And again, it is a pregnancy category D. So caution with contraception and contraception advice. Caution also with a past history of pancreatitis, just like the GLP-1 receptor agonists. Average weight loss, we're now looking at 21% average weight loss, and 2 in 3 patients will lose more than 20% of their body weight. Important to know, though, that there have not been yet any head-to-head trials, or the data has not been out. There are some head-to-head trials, but no data yet. But on tirzepatide versus Wegovy, there are some trials or some data comparing the two medications and the trial data, but those trials were done as different trial settings, so we can't really compare them directly. But we know that both of these newer medications, Wegovy and Mounjaro, we are achieving greater than 20% total body weight loss in a significant portion of patients. And this is starting to approach bariatric surgery. So again, it's a weekly injection. The starting dose is 2.5 milligrams, and it's recommended that it's escalated every 4 weeks up to 15 milligrams. So there's 6 different dosages. At the highest dose of 15 milligrams, we're looking at $690 a month. At the lower doses, we're looking at around about the...
380.
Yeah, thanks, Anna. Needed confirmation there.
There is a couple of questions here, which some will be relatively easy to answer. So we've answered can we go from 1 milligram Ozempic to Wegovy, 1 milligram? Yes, the answer, you can direct swap. How to shift from Saxenda to Wegovy and what dose to start. The advice from the pharmaceutical companies would be that, I mean, they are different medications. Yes, they are both GLP receptor agonists. However, one is a short-acting, one is a longer-acting. So they would say to start going from Saxenda to Wegovy to start at the 0.25 milligram dose. We, and I'm sure Teresa has probably had similar, if you start them at the 0.25 milligram dose and they are really not getting any effect, I would say that it is absolutely safe to escalate that a little bit quicker if you feel that the patient is coping. There is no point dragging it out if they're not getting any effect at all. So that's the only thing I'd say about that. Regarding the new Mounjaro pens, is there a way to use the click method? Again, pharmaceutical company advice would be to say you shouldn't do that, purely because they can't guarantee that you will get the exact amount of the medication according to the clicks. However, we all know patients are figuring their own ways around that, but the advice from the companies is no, we shouldn't. If a patient already has gallstones, conservatively managed, I'm assuming not giving them any issues, is there a problem starting a GLP-1? The answer is yes, you can do that. And again, monitoring as you go along. Weaning people off GLP-1 agonists.
Yeah, so I think that's a very interesting one. If you look at the trials, when people are removed from the medication over a number of weeks and months, they regain about 1/3 to 2/3 of their body weight. So they don't jump up like we used to see with medications like phentermine. I think there's a big difference between weight loss and weight maintenance. And I normally clarify that with patients. So when patients kind of reach a target weight, and look, we don't like to actually set a target weight, but we'll find patients' weight loss will start to plateau off. They'll start to actually become very comfortable with where they're at. We'll see lots of health benefits. I'll then talk to them about the maintenance phase. Sometimes I will reduce the dose of the medication and see how they go. I rarely stop it immediately. I would normally give them a bit of a build-up phase where they can work on their lifestyle modification that we've already been working on the whole time. Sometimes I'll use them sporadically, so they might decide to come off them, and I'll say, okay, let's set a margin for your weight. If it increases by more than, if we set 3 kilos, then let's go back on it again. Just like any chronic health condition, we don't just stop medications and expect people to be cured for life. So we need to treat it just like any other and monitor patients. I think the question about using GLP-1s receptor agonists in elderly people, and is there an age limit? No, there's not an age limit. I know our oldest may be 85, Zana, or something like that.
Yeah, one of mine's 89 actually. So I can answer that in terms of the elderly. Look, I think look, they have been proven to be safe. However, we know that all the GLP-1 agonists are primarily renally cleared. And so the only advice that the companies would say is just to really look at the kidney function before starting. And they don't really recommend to start it if the GFR is less than 30.
Yeah, I think the other important thing, the concern with the GLP-1 receptor agonists and some of the data that's come out is of muscle loss and potentially leading to sarcopenia. Whenever anybody loses a significant amount of weight, they're always going to lose some muscle. We like the ratio of fat to muscle to be 1 kilo of fat, or 1 kilo of muscle to 4 to 5 kilos of fat. That's a reasonable ratio. So the most important thing that I would absolutely be prioritizing is that we discuss protein intake with all of our patients, ensuring adequate protein intake and resistance exercise. They're the 2 crucial components. We know that we start to lose muscle mass from the age of about 40. And in females, we have that double whammy of when we hit the menopause, we start to lose it even more because of estrogen reduction. So really from the age of 40, that resistance exercise combined with good protein intake is absolutely crucial. So I think we've probably, someone wanted to know the difference between Ozempic and Wegovy. They're exactly the same drug company. It's semaglutide, that's the chemical in it. It's just rebranded. So Ozempic has 3 dosages, 0.25, 0.5 and 1 milligram, and that is specifically for patients with type 2 diabetes. And since the 1st of June, it's been on an authority script for management of diabetes, poorly controlled diabetes. So they have to fulfill the criteria. It is PBS listed for that category of patients. So obviously it's going to be much cheaper. Unfortunately, Wegovy is more expensive, even than off-label private prescribing of Ozempic. Wegovy is more expensive for the same dosage of the 1 milligram dose. However, we need to follow TGA guidelines, otherwise we're going to end up with an Ozempic shortage again. Is there any way of assessing visceral fat objectively? Waist circumference is a reasonable in-office method to do it if you have the benefit of the body composition analysis scales, which are the bioimpedance scales that can look at visceral fat, and that's an excellent tool that we do use here. Another excellent tool is grip strength, and we also use that to assess for sarcopenia.
Another quick one is, what do we do if a patient responds really well to a GLP-1 initially but starts to plateau? Amazing question. So I think that brings up two main issues here. Weight plateauing is very, very normal. We don't expect if we keep someone on a GLP-1 that they will just continue to lose weight. You can't continue to lose weight, otherwise there'd be nothing left of a person. So when weight plateaus, quite often we have to do a lot of education with our patients to say, yes, your weight will plateau, and that is absolutely normal. And we talk all the time about sometimes weight plateauing and leveling out that may actually be where you're genetically meant to be from a weight perspective. And in fact, keeping the weight stable is a really good achievement, because sometimes taking them off a medication might mean that they will weight regain. And so maintenance of weight, using these medications for weight maintenance, is a very legitimate thing. And there is absolutely nothing wrong with continuing a medication for weight maintenance.
And on that note, I'll just mention that some people get concerned if their patient's BMI has reduced significantly and theoretically they don't qualify for the medication anymore. We know if we stop it, they will regain. So it is very reasonable to continue a medication. Obviously, if someone's BMI is dropping too low, we need to be mindful of that and make sure we're not tipping into eating disorder territory. So I'm actually going to leave it here because I know Zanna has a lot to talk about. That's just a schematic of where tirzepatide can work. GLP-1 and GIP works on the brain, pancreas, and as I mentioned, the white adipose tissue or the fat cells. We have got a few more slides on this actually. The evolving G agonist revolution. I won't go into this in detail, but just to mention there are a lot of medications in trial phase, some oral, some injectable, and we're starting to develop more of the dual and triple agonists, so with amylin and glucagon, as well as the GLP-1 and GIP. There are benefits beyond weight loss when we're talking about GLP-1 and where it works, and you can see it does work in multiple organ systems. And I'm just going to briefly touch on some of the most relevant trials that have become evidence. So if we're looking at semaglutide 2.4 milligrams or Wegovy, when we're looking at heart health, the SELECT trial was probably one of the most groundbreaking trials to bring evidence to light, and the cardiologists are very excited with this. So it's in those with cardiovascular disease and overweight or obesity, and it showed 20% reduction in major cardiovascular events, so including heart attacks and strokes. The STEP HFpEF trial, looking at heart failure with preserved ejection fractions, showed reduction in symptoms and improvement in exercise function. Renal health recently released the FLOW trial data, and that's looking at patients with chronic kidney disease and type 2 diabetes, and it showed a 24% reduction, lowering of major kidney events. So again, incredibly significant. Hepatic health. Now, this data from the Essence trial was just released 2 days ago, and that looked at MASH, which is the new metabolic associated steatotic hepatic disease, and which was the old fatty liver disease. So MASH and stage 2 or 3 liver fibrosis, it showed 37% improvement in liver fibrosis, and 63% achieved resolution of steatohepatitis, so significant. There have been some trials with Saxenda as well, but this one is pretty significant with semaglutide 2.4 milligrams. The other really exciting one is with tirzepatide and showing respiratory benefits. So the SURMOUNT OSA trial looked at patients with moderate to severe obstructive sleep apnea and obesity, and it showed a reduction in events, AHIs, apnea hypopnea index, so the number of events per hour. It showed a reduction of about 30 events per hour, which is quite phenomenal, and that was independent of weight loss. Also reduction in the hypoxic burden, improvement in CRP, and we see that commonly with weight loss itself, but also there's independent effects from the medications and also systolic blood pressure. There are many trials in evolution now, and there'll be new ones coming out all the time. So, but they're the ones that I think are really pivotal trials.
Now, we love all these questions. We're just going to park some of them just for a little bit, not because we can't answer them, just because we do want to just briefly touch on bariatric surgery or the other surgical options, just to complete the story, I guess, of in its entirety of how we can manage weight. So I want to just briefly talk about intragastric balloons. Some of you may know about them, and some may not. But what are they? They are really space-occupying lesions, not lesions, space-occupying devices that reduce the capacity of the stomach for food. They do delay gastric emptying, and therefore that's what gives the satiety feeling. They are reversible and minimally invasive, and they are for anyone with a BMI over 30 or over 27 with a weight-related complication. There were two original intragastric balloons that were able to put down endoscopically. The first is the SPAX-3 balloon, which I believe is still around. Not many are put in nowadays. The balloon can stay in for 12 months, that one, and produces around about 16 to 20% weight loss. So that's quite significant. Then there was the Orbera balloon, which is a 6-month balloon. And so both of these balloons have to be taken out after the respective period that they've been in. And the Orbera produces around about 12 to 15% total body weight loss. But again, they do need to be removed. And once that device is removed, then quite often people will describe a feeling of less satiety once that balloon is removed. Then the newer kid on the block regarding balloons is called the Allurion. It's a non-endoscopic balloon. It comes as a capsule attached to a tube. The patient does swallow that capsule, and then we confirm the placement of that, and then that balloon is filled with about half a litre of a particular saline. An X-ray is used to confirm the placement, and then the tube is removed, so no anaesthetic required, and then the balloon stays in place for about 16 weeks, and the filament inside the balloon at around about 16 weeks slowly degrades the balloon, which then the balloon gets a slow leak, and then the patient passes the balloon naturally. So the Allurion balloon can produce around about that 10 to 15% total body weight loss in 4 months. However, similar to the other endoscopic balloons, once that balloon goes, our patients do quite often say, I did feel a return of my hunger. However, we do find that sometimes they're a good kickstart to weight loss, and patients can quite often use that as a chance while the balloon's in and they're feeling less hungry to be able to work on those lifestyle measures that we talk about all the time with our patients. Moving on to bariatric surgery, and this is where I spend, I guess, probably a third of my time during the week is in the operating theatre with the surgeons, and we do have varying procedures that we do, and I want to talk about an older surgical solution that we don't do as frequently anymore. So these are our surgical procedures. We've got the laparoscopic adjustable band, which I guess has had a bit of a bad rap over the years. And I do want to talk a little bit about that because there's still a significant amount of our patients in the community that you will see that have a lap band, and we need to know how to manage those. The two main procedures that are done today surgically would be the sleeve gastrectomy and the gastric bypass. And there are two different types of gastric bypass, the Roux-en-Y and the one anastomosis. The one anastomosis gastric bypass has other names. People have either called it the omega loop, or some people call it the mini gastric bypass. I will let you know there's nothing mini about a mini gastric bypass, and I'll tell you the reason why in a minute. So the laparoscopic adjustable band, minimally invasive procedure. It is completely reversible though, so they can be removed. It really restricts the amount of food eaten by exerting a gentle pressure to the top of the stomach. It is attached to a port which can be accessed, and we can access that port to put fluid in, which makes that band a little bit tighter, or take fluid out, which makes it more loose. It provides gradual weight loss over time, but they are high maintenance, so patients need to come back frequently for adjustments. They can, though, produce around about 25% total body weight loss. Like I said, they are rarely performed now purely because there are better options. And look, they have over the years produced quite a high percentage of what we call dysfunctional eating. So if you hear any of your patients that have had or have got a laparoscopic adjustable band where they are vomiting or cannot tolerate a good amount of variety of foods, that is, I can't emphasize this enough, that is not normal. And so if you have any patient that is constantly vomiting and can't tolerate food, please refer them back to their bariatric clinic where they can have that band adjusted. That's all I'll say about adjustable bands. Sleeve gastrectomy. If you look at the bariatric surgical data for the last year, that the sleeve gastrectomy is the main surgical procedure that is performed not just throughout Australia but around the world. It removes about 85% of the stomach. So we staple along the stomach. I don't know why they call it a sleeve. I think they should call it the tube, really, because it creates a tube-like structure, and we remove the stretchy part of the stomach, which goes in the bin. So most people think that it is purely about restriction. So it restricts the amount of food able to be consumed, which it does do. However, in both the sleeve gastrectomy and the gastric bypass, there is a very strong hormonal effect, which is why they are so effective at weight loss. So when we remove a lot of the stomach, that's where a lot of the ghrelin or the hunger hormone producing cells are. So by removing that, people wake up from a procedure like the sleeve and they will say to us immediately, I cannot believe my hunger has gone. Well, not gone, but pretty much gone. And that is because of the significant reduction in ghrelin, the hunger hormone. But we also know that those satiety hormones, particularly GLP-1, they increase. So that's why people feel very full after eating a smaller amount of food, is because of the change in these hormones. And people will feel that immediately. We're not entirely certain of the mechanism by which GLP-1 increases after bariatric surgery, but it does. And people have that effect to varying degrees. It can last 2, 3, 4 years, can last even longer than that. But there are some people down the track that do report a return in their hunger down the track and a reduction in their satiety as time goes on. That is actually normal. It's not a failure of the procedure. And that's where some of these pharmacotherapies can come in really useful in adding them in if there is some weight regain down the track after bariatric surgery. The sleeve will produce around about 30% total body weight loss, which is very significant. However, we do know that about a quarter to a third of patients will regain some weight at some point in their post-operative journey post-sleeve. It is not because they've stretched their stomach. Most of them will feel this real sense of failure if they weight regain. Our motto at our clinic is no, we don't ever use the F word, fat or failure. When patients regain, they have not failed. This is a chronic disease that we are treating. And just like we treat any other disease, we would say, okay, you've had a relapse or a progression in your disease, so we need to escalate treatment. They are not failures. Long-term follow-up after any bariatric procedure is crucial. Some of these patients can develop some nutritional deficiencies if they're not monitored, and so they will need regular blood tests and vitamin supplementation for life. Looking at the gastric bypass now, so there are, like I said, there are two types. The Roux-en-Y, which is I guess the traditional gastric bypass, which has been around for about 70 years, I believe now, Teresa, correct me if I'm wrong. It was initially invented for as an anti-reflux procedure, and they just happened to realise that patients lost a lot of weight. And then there is this one anastomosis gastric bypass. Basically, a gastric bypass is making the stomach smaller, like the sleeve. However, we're also rediverting the passage of food into the lower part of the bowel. They will both do that, just by slightly different mechanisms. The only difference between the Roux-en-Y gastric bypass and the Omega loop, or the one anastomosis, is that with the Roux-en-Y there is 2 joins, and with the one anastomosis, as its name implies, it has 1 join, but they function in exactly the same manner. So yes, you'll get restriction of the amount of food able to be consumed. However, there is a very strong hormonal effect, as with the sleeve, in the reduction in the hunger hormone ghrelin and an increase in the satiety hormones, particularly GLP-1. The feelings of reduced hunger and increased satiety, patients love. They talk about reduction in food noise, that they find it a lot easier to maintain their weight loss down the track. The difference between the sleeve and the bypass, with the bypass, you get significant malabsorption. So there is significantly reduced fat and sugar absorption, which is a very powerful mechanism. And that is one of the reasons why following a bypass I guess they're a little bit more likely to maintain that weight loss down the track. However, it is still possible to regain weight after a gastric bypass. It is considered the gold standard, particularly when it comes to treatment of type 2 diabetes, because of that significant reduction in the absorption of sugar. And you're getting slightly more weight loss with a bypass, around 35%. However, your risk of nutritional deficiency following a bypass is greater than a sleeve, and these patients really do need long-term follow-up. So that's about it in terms of our presentation, but I do want to very briefly touch on referral pathways. You've seen this slide earlier. I can't emphasize enough the importance of a team in managing our bariatric patients. As with any chronic disease, we can't do it on our own. We do need our allied health and specialist partners in managing these patients. But the importance is the communication that we get between all these members of our team. There were a few other questions that have kind of disappeared now.
Zana, I have actually typed the answers to all of them in. I think, unless I'm hoping I have answered them all, but please type if there's any more. Oh yes, sorry, that was one I pressed send too early. It was about bariatric supplements, I think. Yes. Do you have any specific formulas? So there are specific bariatric supplements available in Australia, and it is very important because they have very different levels of micronutrients. With a lot of the over-the-counter, the supplements will find deficiencies in things like zinc, copper, selenium, magnesium. We'll often also see toxicity of vitamin B6. So the two that we use most commonly in Australia are called BN, or bariatric nutrients, and Fit for Me.
I do want to answer this question because it's very important. How do you address dumping syndrome post-gastric bypass? In fact, dumping syndrome you can get post-sleeve and bypass, more commonly with a bypass, and a lot of people think that their procedure, they're having a complication. By sort of a definition, I guess, dumping syndrome is mainly with a bypass, and the reason they will get that is if they consume a meal that is very high in fat and sugar. And the reason they get that is because the part of the bowel that we bypass used to absorb all of that fat and sugar. And following a bypass, they're not getting that. So that high fat, high sugar load will get dumped, so to speak, straight into the lower part of the bowel that actually really doesn't have the capability to be able to absorb that. So the high fat, high sugar meal then can draw water into that, into the bowel, and so they can get symptoms like diarrhea. They may feel extremely unwell, like they want to vomit, and they may vomit. They might get things like they start to sweat and will get maybe a tachycardia or get some heart palpitations, and it's not a complication. It is actually teaching them, I guess, to not consume those meals that have such a high sugar or fat content. And most of our patients, if we educate them well, they will say, if I avoid most of those things, I'm actually fine and I don't get those symptoms of dumping syndrome. But it is a bit of a continuum. We will have patients that will say, yep, I can have a small handful of hot chips, and if I do that, I'm absolutely fine. But if I push those boundaries and have more than that, I'll start to get symptoms. And if I have a lot, yep, it's all over Red Rover and I won't feel very well. So in a way, it is teaching them about I guess, the more appropriate foods to eat and also what not to eat. So that's how we manage that is purely dietary in the initial phases.
Dana, would you like to answer? There's one more question there. How would you involve a psychologist in a proper way, especially if there is emotional eating? Now, we could talk about this forever,
We could
but
talk
I
all
will.
day on that. And I'm glad someone mentioned psychology. That is a really important part because we consider educating our patients before bariatric surgery on the importance of decent psychology, because having bariatric surgery will not necessarily take away a patient's desire to emotionally eat. So we talk a lot before bariatric surgery about, yes, you'll lose weight, but it is not going to necessarily take away your wanting to emotionally eat, particularly if you're stressed or upset or angry. If that is your coping mechanism, we need to actually look at finding other ways to deal with stress and anxiety in your life that's not food related, which for some patients can be very anxiety provoking. And so we would want to really send them to a really good psychologist that understands weight and that understands that binge eating and emotional eating path, sort of process. We can use the new eating disorder, chronic disease, eating disorder plans, and that gives patients a greater access to both dietetic services and psychology services. They can get, I think, 20 dietetics and 40 psychology. That is a huge help to our patients when it comes to access. So yes, we would absolutely do that. In terms of naming some psychologists, it really depends where you are. There is a register that you can look up. There is, I think, on the ANSMOS website, there are psychologists that you can look up that have special interest in eating disorders or disordered eating, and also those that have had bariatric surgery as well. So that's ANSMOS, the Australia and New Zealand Metabolic Surgical
Obesity Surgery Society.
Surgical Society. ANSMOS, if you Google it. So, yep.
And the other one is NACOS.
NACOS.
NACOS. And if you have an interest in this area, it's free to join NACOS, and that stands for National Association for Clinical Obesity Services. So that's both medical and surgical focus, and any GPs, but also allied health can be part of NACOS. I think we may have run out of time, Zana. So I think we may. Oh.
Teresa, is it okay if I share that screen for GoShare program?
That'd be fabulous. Thank you. Sorry, are you sharing it, or did you want us?
Yes, I'm going to share.
Oh, okay. Yeah.
I did open it and then
That's okay. So the
Yeah.
GoShare Healthy Lifestyle program is put together by Preventative Health SA, and that's particularly for access for rural patients to be able to access some lifestyle advice, and this will be sent to everybody after the webinar, I believe.
Yes, so we will send out the certificates by next week, and we will attach all these as static attachments.
Wonderful. And we can certainly send out, if people haven't seen it before, the Australian Obesity Algorithm and the paper associated with that. I think that's an excellent resource. And if there's anything else anybody would like that was discussed, or any of the data or studies, please just forward it to SAPMEA, and we can certainly send those through as well.
Thank you so much, Zana and Teresa, for sharing your valuable insights and expertise with us today. So I truly appreciate your time and effort you dedicated to prepare this presentation. And I hope all those who attended tonight gained some valuable knowledge and skills and can apply that, what they have learned today. Thank you once again for your contributions. And before everybody leaves, I would just like to remind them that this session is funded by Country SAPHN And one of our KPIs is to provide them with the evaluation of the sessions. So we would really appreciate if you can complete the evaluation form. You will get a pop-up box with the evaluation form, and it only takes 2 minutes to provide that. But it will really help us to continue our services. So thank you everyone once again, and I hope you enjoyed the session.
Thank you. And
Thanks for all your questions. They were
Yeah.
amazing.
Yeah, really
Yeah.
appreciate that. Yeah, this is the first session I've seen so many questions, to be very
yeah, it's
frank.
wonderful. It makes it much easier for us to,
Yes.
to have that interactive session. So
Yes.
thanks everyone and have a great night.
Thank
Enjoy your
you. Good
evening.
night,
Bye.
everybody.
Thanks.